Welcome to our info share. My name is Chuck Hill. I am the Provider Relations and Network Development Director for MeckLink Behavioral Healthcare. We have a packed agenda today, so we really need to get going. The one announcement I have for you, and I want to make sure everybody is aware of it, is if you're a licensed independent practitioner, a group practice, or a hospital, that application process is now available on our website. If you go to News and Features, it's the second item down. There's a link that will take you to the website related to that. There's a link on there to our document management site, which is with MedVersant. MedVersant is also our CVO, who will be doing the credentials verification and the background checks for your licensed independent practitioners. Now, if you're an agency who submitted your agency application, we will actually be emailing you a separate process for your LIPs to submit their applications. So, again, if you're an agency, this process is not for you. It's only for licensed independent practitioners in standalone practices, group practices, and hospitals. At this time, I'd like to ask Gail Butterfield to come forward. She wants to do a brief presentation on training.
So we have several different ways that we are going to roll out training. There will be some face-to-face trainings. There will be some trainings that will be on the internet, which I will show you in a few minutes. And hopefully there will be some trainings where we'll be able to start building our local resources in our community, like we did with the service definitions trainings. One of the first trainings that we'll have here, first Train the Trainers, is the Locus Cal Locus Train the Trainers. Okay, on December 3rd at the Watkins Center, we will have someone from the NC Council coming down to do the Locus Cal Locus Train the Trainer. If you look for the hot sheet, I will be sending out the flyer. I also will be sending it to the Provider Council Training Subcommittee. There will be several venues to introduce trainings when we have new trainings coming out. One of the things, everything will always be in the hot sheet. So if there's a new training, you'll be able to see it in the hot sheet. On the Provider Council, the public page for Area Mental Health, or MeckLink Behavioral Health, excuse me, it'll be on there, which I'll navigate that in a few minutes. Here at InfoShare, we'll be announcing new trainings that'll be rolling out. And the biggest part will be working with the Provider Council Training Subcommittee, as we did in the past, to try to roll some of these out and also build our resources in our community. This is the MeckLink Behavioral Healthcare public page. And if you come over here where it says for providers, you'll click that link, and it brings you to this page. And over here, we've developed a section, and it's called Provider Training. I'll click on it in a minute. And it's where you can view the upcoming provider trainings, but also online courses. So if you click this link, it brings you here, okay? These are all of the trainings that, on this training calendar, these trainings are the trainings that are offered by MeckLink Behavioral Healthcare, and it's open to the provider community. Up here, we have where you can view the online courses. So if you click here, there's one course out here at this time. The course is the overview of Medicaid program integrity, okay? Who's recommended or required to take this course? Well, it's required for all employees because it gives you a really good overview of the Medicaid program integrity. Your employees should know this, as everyone from the CEO down to the admin staff. Everyone should know that. So there's a course description. Then you click this link to take the course. Okay, once you get in here, you can click on this link and it'll bring you to the slides. After you go through the slide presentation, you can just X off, which I'm just going to go ahead and do now. And then you can click next, and it will take you through the test. You can answer the questions, If you pass the course, then it will take you to a page where you'll be able to fill in all of your demographics. It's going to ask you questions. It will not let you go forward until you have completed all of the answers on that page, because what you write on that page will convert into my Excel spreadsheet, so we'll be able to have all of your information. If you do not pass the course, then it will tell you that you did not pass, and it's going to prompt you back to the slide presentation where you'll review the slides again, and then it'll give you the opportunity to go ahead and take the course again. Okay, one other thing, NC TOPS training. We've been offering NC TOPS training at the Watkins Center. Beginning in November, we will be putting all of this online. Okay, so everything that we cover in the face-to-face class will be out there online. So it gives you an opportunity to do it at your own, in your own time and at your own pace without having to leave your workstations to come over to a training. So it's a win-win for both of us as we move, and there are more training requirements. There are other requirements that really need face-to-face time. So we're trying to be really considerate of your time for your employees. So I look forward to working with you, the Provider Council Training Subcommittee, and helping to establish our local resources and through rolling out our training initiatives for the waiver.
In terms of training, I also wanted to mention to you the Alpha MCS training that is coming up next Wednesday right here from 9 to 11 is the overview training. It's an open meeting, so there is no registration for that. I think right now, and I was not in the office yesterday, but when I left the office on Monday, there were only 14 slots left on the 31st. No slots now? Oh. For the 31st, there are no slots anymore. So if you haven't registered for one of those trainings, you can come to the training next Wednesday. But we will also be offering additional training dates, and we're also investigating how we might be able to do those in terms of webinars or WebExes to you as well. At this time, I'd like to ask Dr. Carol Litch to come up. She's going to be starting the main presentation today from the Utilization Management Department.
Good morning. How are you today? So we're going to talk today about the Service Management Division. As we go through the presentation, it's going to be a group of us because we work as a team, and there are specialties in our division, and those folks can address them as we move forward. So as we're talking, you're going to hear from me. I'm going to provide an overview of the Service Management Division, as well as talk about our staffing processes. You'll next hear from Stephanie Porter, who is our new Senior Manager for Customer Service. She will talk about how the call center is changing and will change. And you will also hear from Sean Meeham, who's our lead trainer in UM, and Christy Bergen, who is our mental health substance abuse manager for that particular division. We're going to ask that you reserve your questions for the end of our presentation so that we can address it all as a team as it relates to questions, and so we won't, be all day doing this. I want you to know also that this is a perspective look at what service management is going to be doing, so that once we move into the waiver, you can anticipate some of the changes that we will be making. Now, a lot of what we will be doing as we move into the waiver is business that we're doing already. But there are certain changes and requirements as it relates to Medicaid and our review of services that are going to be important. Now, for those of you who are working with value options, those changes won't be particularly new to you because you're doing it already. And those are responsibilities and accountabilities that you manage already. For those of you who will be new to Medicaid, then it will be a surprise and you'll have lots of questions, and we hope that we can answer it to the best of our abilities. The things that we hope to cover today are providing you with an introduction, and we're very lucky today to have many of our managers present, which is a blessing in that the call center, you're on the phone all the time. So because we've increased our staffing, we were able to invite 3 of our call center managers who are here. You'll see Rena White. She is our STR manager. Ema Veal, who is our STR manager, and Kimberly Paul, don't call her Kim, she don't like it, and she is our intake desk manager. We also have Chip Kale, who is our DDUM manager, as well as Christy Bergen, who you will see speaking later. All right. We also will talk about our staffing. We do have some new UM staff here who are present, and we'll go through their names as we go. And we will talk about our primary functions. We will spend a few minutes talking about UM and UM's primary function because everybody's interested in knowing how that works. Again, we ask that you reserve questions to the end, although if you have an absolutely burning question that you just need to answer at the time, we're not going to say, no, we're not going to answer that question. All right, let's get started. All right. I've added some pretty pictures throughout, so it'll be a little interesting. All right, so service management consists of 2 units. You may have been familiar before that the UM director, Martha Jocelyn, who's retired, she managed the call center, she managed UM, and she also managed care coordination, or ICM. Well, we've divided up the divisions into care coordination, which you've heard Dr. Pulili speak about her program, and service management. The reason that we did that, although we will be working together, is that care coordination is a function that will provide direct service to consumers, where service management is a function for authorizing those services. And we require a firewall between those 2 divisions, so that's why care coordination is separated from UM. Although we'll be working together as it relates to making sure that consumers are getting the right service, in the right time, and in the right amount. All right. So service management then consists of 2 divisions: the customer service call center, which you all formerly knew as MeckLink. We're all now MeckLink Behavioral Health Care. But if you call asking to speak to MeckLink, we'll know what you're talking about. We also are utilization management. So in terms of how we are staffed, the medical director, Dr. Alan Melvin, and our clinical director, Dr. Peterson Vita, provide direct clinical oversight over our services. They make sure that the recommendations and decisions that we make are clinically sound, and they are ultimately responsible for approval and denial of services. You'll see that the lines between Dr. Melvin and Dr. Peterson and myself are dotted because they're not my direct supervisor. Mr. Phil Indress is my direct supervisor. Then you'll note solid lines between our 2 units, our programs, which are our senior manager for the customer call center, which I am so glad she's here. Stephanie Porter, and our senior manager for UM, Paige Walter, who I couldn't have done this for this long without. All right, so let's talk about our call center staffing real quickly. It's divided into 3 separate programs. And Stephanie will talk, as she talks about what our major functions are, she will talk about our programs. So Kimberly Paul, who you saw over there, is going to be our manager for intake help desk. Now this is a new program in service management, and it will be situated to be able to answer provider questions. Stephanie will go over some of the functions as we continue this dialogue. Then we have 2 managers for the clinical aspect of the call center, Ema, who you met, and Rena, who you met. And then you will see our staffing as thus. In the call center, our phones are answered, will be answered 24/7. So after December 31st, we will be managing a 24/7 call center. We do now, but CMC Randolph, thank you very much, has been answering our calls after hours and on weekends and on holidays. So in the future, we will have staffing after hours. We're still working out the details on how that will exactly look. Those of you who have been applying for positions will note that an after-hour staffing positions are listed on the website. So the way that the call center will work is that the phones will always be answered live. We will have licensed professionals who will be there to provide triage, screening, and referral. And we will also have non-clinical people who will be responsible for answering provider-related issues related to claims and other concerns. Our UM staffing is pretty much the same as it always has been. Paige Walther, who is our senior manager for UM, is responsible for operational oversight of the UM department. Chip Kell is our manager for developmental disabilities, and Christy Bergen is our manager for mental health and substance abuse services. As you can see, we are getting there in terms of staffing. Hopefully, with our next interviews and our postings, we'll be close to completion. And some of our UM staff who are brand new to our division are here today. Say hey. Okay. All right. The service management division, all of our care managers, our URS, are licensed clinicians. They have master's degrees in mental health discipline and at least 3 years supervised postmaster's experience. Our care managers have a variety of licenses, and they are qualified professionals. And again, we do have non-clinical position in the call center who will help us with answering our phones. And we do have one non-clinical person in the UM division who's responsible for managing the slots, or who will be responsible once we find that person, for managing the slots related to innovations. But that individual will not be doing any authorization of services. So I'm going to turn over this conversation to Stephanie Porter, our call center manager. She's brand new, so be kind. And then you'll see me a little later.
Good morning. Can everyone hear me okay? Hope I'm not too loud. And this is new to me, so forward is the right button. Thank you. My name is Stephanie Porter. I'm brand new with MeckLink. Today will be 2 weeks that I've been here. I'm the senior manager for the call center. The call center is going to be going through a lot of changes. We want to become more customer and consumer friendly for both providers and the people that we serve. One of the biggest things that we will start to utilize on October 29th will be the Alpha MCS system. I'm sure some of you are aware of that. Mr. Hill just talked about some of the provider training that will be coming up. This system is going to help our call center function at a much more efficient level than it has been. I think we've been doing a great job, but we're going to be able to do lots of things with the new computer system starting on the 29th. The customer call center serves as the main portal of entry to the MeckLink Behavioral Health Care Network with primary functions that include the enrollment and eligibility. We check the Medicaid eligibility of every consumer that we talk about on the phone, or we also look at their eligibility to receive IPRS funds. We do a screening, triage, and referral process, which is referred to as STR. These calls are taken in and screened by a licensed clinician and either categorized as routine, urgent, or emergent, with routine being a basic call, urgent being kind of a moderately serious call, and urgent being something that needs to be handled immediately. We do dispatch law enforcement or 911 emergency personnel if needed, but our staff is fully trained to handle those types of calls. We also will be doing the intellectual developmental disability eligibility for the new innovations eligibility screening, the SIS. We manage the registry of unmet needs. That means we add IDD consumers to the list when they need services. And we also will be doing referrals to care coordination starting January 1st. Pre-certification for hospitalization and initial assessments for service. This is what includes our three-way contracts with Presbyterian Hospital. We have 5 beds that we contract with Presbyterian to put people in who are indigent that need crisis services. We also will follow up with calls and make sure that the dispositions of the calls are dealt with properly. Record maintenance. This is going to be part of our administrative calls management function, and I'll talk about that in a second. The call center will also always handle general complaints for consumers or providers. Kimberly Paul, who you met earlier, will be our new manager she is our new manager for the administrative calls management part of the call center. This is the intake help desk, and it will be information for providers to call in and answer questions. And it's kind of like the provider side of our customer service part. We will act as the first point of contact for administrative questions or problems for providers. This will be primarily staffed with non-clinical people, and if it turns into a clinical call, then the call will be transferred to someone who is licensed. Research and answer claims adjudication questions, provider contracting issues, and provide general complaint resolution for providers. And they will also be responsible for making sure that the STRs that are entered into the system are complete and that the information is accurate. So they will have a QI function as well. STR, screening, triage, and referral. Ima Veal and Rena White are the new managers for this section of the call center. Starting January 1st, we will be providing 24/7 customer service call center availability. As Dr. Litch mentioned earlier, right now our after hours and weekend calls are handled by CMC Randolph. They also handle our overflow calls, like if too many calls are coming into the call center, they'll take the calls that they'll be routed to them. But we will be doing a 24/7 operation starting January 1st, and we're currently be in the hiring process to hire those people to work nights and weekends. Triaging all incoming calls for clinical severity by the North Carolina Standard Protocol. This is the urgent, emergent, and routine categories. We will also do telephonic assessments to determine the level of urgency and the nature of the presenting issues. Again, as I mentioned earlier, if we have to dispatch emergency personnel, we'll be able to do that. And we will also be the portal of entry for care coordination referrals. The one cool thing about the Alpha MCS system is now when the providers call in, we will be able to schedule consumers with the provider through the Alpha MCS system. You will be able to see your side of the system, and we'll have our side, and you can open up appointments that are available with your agency so that when we have a consumer that calls in, we can look and see what you have available and put that person in your slot. And then you will be able to see that on your side. So we will have a scheduling capability, which I think consumers and providers are really going to enjoy. And we also provide follow-up to ensure consumers are accurately connected to the services and receiving appropriate care. We follow up to make sure that consumers come to their scheduled appointments and that everything runs smoothly. The customer service call center will act as a portal of entry for referral to care coordination for new consumers enrolling with the MCO and existing consumers being managed by UM. Referrals will be managed in through a daily high-risk team staffing process. This will involve clinical staff from the call center, care coordination, and MeckLink Behavioral Healthcare senior clinical staff. If we have a difficult case that we are referring to care coordination, then we will get everyone in the pot and in the mix to staff that case and make sure that that consumer is addressed properly and that their needs are met. If a consumer does not meet the special health care eligibility as defined in the waiver agreement, then the consumer call center service staff will help to find a place for that consumer. We're not just going to let them sit out there. We want to find something that's going to be appropriate that's in our network. And as I already said, the call center will provide a 24/7 crisis service referral, review and authorize for local community hospitals for both Medicaid and IPRS consumers. Again, right now, CMC Randolph does our after hours. We will also be assisting local community hospitals with discharge planning. When a consumer is placed in a hospital and they are ready to be discharged, we will help that consumer get linked to a provider. We've had some discussion about hopefully doing it face-to-face, but we want to make sure that that transition when that consumer's discharged is smooth and that they get right into services like they should so that there's no rehospitalization or recidivism there. We'll continue to review and authorize initial requests for assessments for IPRS and Medicaid services. And that's the general information that I have for you today, but our goal is for the call center to become very, very customer friendly, easy to use. I'm real excited about being able to help providers get their appointments made quickly, and you can see who we've put into your system and vice versa. The Alpha MCS system is very easy to use. I think you're going to like it. I mean, there's always going to be things that you have to work out and learn, but it's really going to make the call center a state-of-the-art program. So that's it.
Good morning again. I'm Christy Bergen, and I'm the Utilization Management Manager for Substance Abuse and Mental Health Services. And standing next to me is Sean Mann. He's one of our care managers in the UM department and also one of our lead trainers. We're happy to have him here today to help us go over the UM department. So I'll be Vanna assisting.
Good morning, everybody. Thank you for being here today. Wanted to talk to you guys a little bit about utilization management. I know most of you are familiar with it, and I've seen a lot of familiar faces today through the trainings that I've done in the past, but we wanted to kind of talk to you guys about some of the changes that are upcoming. As Dr. Litch mentioned before, a lot of those changes won't be too different from our business now, and a lot of the things that we're doing now will continue as we move forward. First of all, the purpose of UM. With UM, the bottom line is we want to make sure that enrollees receive clinically appropriate services. That's the main goal for utilization management. We review a variety of services, both on the mental health, substance abuse side, as well as the DD side. And our potential consumers or enrollees could be any Mecklenburg resident that is dealing with an IDD, a mental health or substance abuse problem. Somebody who currently does not have insurance, does not have any other MCO participation, or they've been denied services in the past by those insurers. So those are our potential customers. Essentially what we're saying when we talk about who we want to serve and how we want to serve those people, we have a saying that we're starting to kind of talk more about. It's called right person, right service, right time, right length of time, and right outcome. So those are essentially the things that we want to convey and some of our goals that we want to achieve with our customers. In terms of what we do in UM, we do a variety of things, in terms of the clinical scope. We manage the benefit plan. You've heard a lot about our benefit plans that we use, that we utilize. We also look at a lot of the over and underutilization, and I think a lot of that will come more into play as we move forward, and we're working closer with some of the departments internally. We also look at, obviously, medical necessity. PCPs, which are person-centered plans. I know a lot of you are familiar with those and how much of a role those play with the authorization. We'll talk a little bit more of that in a minute. We look at the authorization in terms of both pre-certification and concurrent review, although we'll learn in another minute or two with the slide that we'll see that everything in terms of the way we look at the authorization is going to be considered an initial authorization. That'll sort of make more sense when we get into that. But another thing we do in UM is as we mentioned before, the innovation waiver slot management and the oversight of that. Also the review and authorization of the intermediate care facilities and the management of denials. We collaborate with the administrative services in the QI department for that, and we'll talk a little bit more about that as we move on. In terms of the authorization, as I just mentioned, we're looking at it in terms of an initial service request, and sort of the concurrency thing is still there, but in terms of how we perceive that on the UM side, every authorization is going to be looked at it as an initial authorization, okay? That's one change moving forward. Again, it's not going to change too much in the way we review that clinically, but it will change the way that we look at that authorization coming in terms of the benefit plan with that.
So the term concurrent, meaning the consumer is already involved in services, already in the service.
We've stressed a lot in the past that we would like providers to request services as early as possible, and a lot of us have even said 14 days in the past, but we really want to make sure that providers understand that the request can be made 14 days ahead of the authorization. And a lot of that is for the benefit of the provider and for the benefit of UM. We want to make sure that there's enough time for us to review that service. If there's any additional information that we need to ask for, if there's any things that we need to possibly staff clinically, want to make sure that there's plenty of room for that. And also to make sure, of course, that there's no disruption in the service with the customer or the enrollee. So those are the main objectives there. We know that there are outliers to that. We know that there are circumstances that come up that may prevent that from happening, and we've dealt with that. But we want to make sure that you understand that that's our goal. So what do we need when we look at these requests? So, in terms of the clinical review, what kind of goes into that clinically? Of course, we look at the clinical assessment, which is called the comprehensive clinical assessment. That is actually a big piece of the review, especially with a new consumer. If a new consumer is coming into service, one of the main things that we look at clinically is going to be that CCA, okay? The other pieces that we look at pretty strongly are, of course, the person-centered plan, which is submitted upon the initial request, and any other clinical documentation that you may have. You can never submit too much information, and the way I look at it as a reviewer is the more information we have, the more resources we have, the easier it is for us to be able to determine medical necessity and hopefully approve that authorization. If we don't have enough information, we will notify the provider, and we will talk to that provider about specifically what it is we need and why we need that information, and we'll also talk to you about a time frame with that. If you're not getting that information from your reviewer, please ask for that. Please ask us to clarify that, because we want to make sure that you guys know exactly what's expected. So of course, if enough clinical information is submitted and we have what we need, our goal is to approve that authorization. We want to move that authorization along. We will, of course, approve the authorization, and we look at authorizations in terms of timeframes, of course. Benefit plans, you've heard that word, we've talked about that. There's a benefit plan according to the service, and there's also a review time frame according to that service. So we're looking at services clinically in terms of the review time frames. And it's sort of broken down. I know a lot of you are familiar with, terms we've used in the past, like routine. What we're looking at now in terms of the breakdown is the pre-certification on the non-urgent side, which is your 14-day, or in the past we've talked about routine. And that typically is the turnaround time. We will turn that authorization around within 14 days unless there's an extenuating circumstance that happens to occur. Pre-certification of the urgent care, which is typically done within 48 hours, but if there's additional information needed, or again, like I mentioned before, we need to go back and do any staffing clinically, it may be 72 hours, but we shoot for 48 hours with that. There's also concurrent review. So we've got pre-certification and then we have concurrent review. Concurrent review occurs much in the same way. We're looking at that in terms of the 14 calendar days for the non-urgent. We're looking at it in terms of the 24-hour, some of you may know it as crisis service for the urgent. And there's also the 48 hours we mentioned before on the concurrent side, or 72 if there are other things we request. In terms of our resources internally, we have a clinical and medical director, as Dr. Litch mentioned, Dr. Peterson Vita, our clinical director, and Dr. Melvin, our medical director, that we have direct contact with and can staff cases with routinely. We actually have formal staffings every week, so we have access to them. If we have any question at all about the clinical nature of the request, we can staff those cases on site. If it does need to go to peer clinical review, we will contact that provider and ask for additional information. We will do everything we can to assist the provider in getting that authorization. It's actually a lot of work for us to send it through to a peer review. So our goal is to try to get that authorization expedited, try to get it approved. If we have determined that we've gotten all the information we can and we cannot make that determination of medical necessity, if we do feel like we need to send that to a peer clinical review, that is another opportunity for the provider to actually present additional information. So it's not the last opportunity. If somehow the information isn't available within the time frame that the reviewer asks or requests it, you can of course, present that information upon the peer clinical review. So there's another opportunity to provide that information. In terms of the peer review procedure, and this is, of course, after, again, we've asked for all the information and we still feel like we can't determine medical necessity, that is actually forwarded to multiple options. It could either go to our medical director on site, or it could go to a contracted agency that we use called PREST. A lot of you are familiar with PREST. That agency provides a telephonic review for us. They do a clinical review, and basically what happens in that process is that MD will make 3 attempts to contact the provider. And if they're not able to contact that provider, if they're not able to make direct contact, then they will do what's called a record review only. So they make those 3 attempts, they leave a message, hopefully that review is completed and they're able to move forward. If not, then of course the record review only takes place, where basically they would review the records that the reviewer, the clinical reviewer, has submitted to them from the provider. So this is the information that we've already asked for, and we typically submit that as soon as we initiate the clinical review, the peer review. We send that to the whoever the person is that's to be doing the review, whether it be the medical director or PREST.
And the provider gets to choose who from their staff participate in that telephonic review. So we specifically ask for the contact name and the phone number so that the provider can choose the most appropriate person that knows the consumer the best and can advocate for them.
And we will do everything we can to work with you and try to identify who that is and make sure that we communicate directly with the person doing the review, conducting the review, and that they have that information. We typically will fax a form over that has all that information on there, so we're giving that information directly on the front end to the person doing the peer review. A little bit more about the peer review. We will send actual written notification if there is a denial. The consumer and/or legal guardian gets a copy of that letter, and the provider gets a copy of that letter. That is the provider rendering the service. So basically what that letter has is, of course, it's got the decision of the denial, and it's got the criteria that was used on the letter, as well as what that person's rights are and an appeal process to pursue. And if that provider has any question in directing that consumer, of course, we're available to assist with that. The appeals and denial process, we're actually going to address at a later date. But we will do what we can on the front end of the review to make sure that there is clear handoff and that is a smooth process. One thing we want to make sure everybody's aware of, which is why we sort of made it bold and big, I know there's been a lot of confusion around this, but care managers do not render non-certifications or clinically deny services. That is done by, as I mentioned before, the MD or the licensed psychologist that is conducting the review. So when we don't have what we need, we are forwarding the information that we have to this person to be able to make that decision for us. A little bit more about clinical denials. We have the authority to approve service requests that meet medical necessity, and those that do not meet, again, are forwarded to the appropriate parties. Again, I mentioned about the letter and what that entails in terms of the appeal process. Basically, the care manager has an option to do an administrative denial when there is a scenario of lack of compliance with the benefit plan. For example, if a provider requests beyond what that benefit plan allots for the units of the time frame, that's an administrative denial. That is not a clinical denial. The other is when there's an incomplete or missing PCP, person-centered plan, and again, we'll work with the provider to make sure that PCP gets in and we have what we need. But if it is incomplete or it's missing within the time frame allotted, then that's an administrative denial. That is not a clinical denial. And there's also lack of pre-certification. And that is basically what we had to talk about with the UM. We just wanted to also mention that in determining medical necessity, we've got also the EPDST criteria and the DMA clinical coverage policies that we will be responsible for in terms of the waiver moving forward. In terms of our assessments that we use, I mentioned a little bit about the CCA. We'll also be using a lot more of the locus and CalLocus in terms of our clinical review. And I didn't mention the ASAM, but that's really important on the substance abuse side. That is what we use in terms of criteria. And on the mental health side, what we use in terms of criteria is, of course, the state definitions. So those are our two main sources for reviewing for medical necessity. And, of course, we have the NC SNAP. And I really want to highlight best practice parameters because we've really been pushing that a lot with the provider network, and I've been involved in an initiative with the person-centered plan. And we're really striving to incorporate that as part of our review process. So right now we're looking at the PCP in terms of best practices, and we hope to move forward in other areas to incorporate best practices as part of that.
It's important for you to know, as Sean went over in talking about what are the information, how do we determine medical necessity. So it's not something that we make up. It's not something that we pull out of our pocket or throw a dart at and say, well, this meets medical necessity, this doesn't meet medical necessity. So as Sean went over, we do look at several pieces of information. The most important information that we will look at is what you present to us in the form of the SAR, which is equivalent to the TAR, which is equivalent to the SDR. So they're all the same thing. But we look at that. We also, for individuals who are in enhanced service, we look at the person-centered plan, and for all consumers, we look at the clinical assessment. So how you present that information will be very, very important in how quickly we are able to move through the through the authorization process. We also will be integrating standardized assessment tools, as Sean talked about, the Locus and CalLocus, and as Gail said, we will be offering Train the Trainer in December, so that you can become familiar with that tool and how it will be used as it relates to the authorization process. It actually is a pretty nifty tool. A lot of people are nervous about it, but it's actually pretty easy to use, and once you get the handle on it, you'll be able to take the information that you know about consumers, mental health, consumers mostly, or consumers with comorbid diagnoses, and then be able to match it with the dimensions and then be able to quickly score the test. So once you are familiar with it, it should take no more than about 5 minutes to complete. We are going to, with the rest of the state, be migrating to the supports intensity scale. Dr. Pugh Lilly and Beth Monaco have spoken about that instrument. Bev Nagy is our new supports intensity scale manager, and she is going to be available to go out with other staff and do those support intensity scales. I asked Bev before, and there's going to be CIS Forum that's going to be scheduled on October 23rd right here in this fellowship hall. So all of you who are interested in coming and learning more about the supports intensity scale, folks from UNC Chapel Hill will be offering that overview and that training. And I will tell you, I went to a pre-forum that was offered at Sam Billingsley, and some interesting stuff. So you'll be excited about it. All right, so, and then of course, best practice parameters. So again, we're not pulling this stuff out of our hat. We want to be as clinically sound as we can be as it relates to our consumers and the services that they receive. As close as we can stick to the clinical parameters, the more likely we're going to have better outcomes for our consumers. So we're going to push you as providers to use your SMART skills to make sure that you're matching clinical need to outcomes that work best for consumers. So we're not, again, we are challenging you to do great stuff for consumers so that we can authorize services that we know that consumers need in the right amount at the right time to get the right outcome. All right, so determining medical necessity. When we look at determining medical necessity, we're looking at several different things. We're wanting to make sure that the service is clinically appropriate. For instance, if a child is having outpatient services and there are family issues that are ongoing, and we know that the issues are happening at home, we would think the next good thing that could be recommended would be intensive in-home, or MST. MST is an evidence-based program, has really great outcomes for kids who have juvenile justice involvement and other types of conduct type behavior. So we would hope that that would be your next logical choice for example, in making recommendations for services for kids. We don't want to keep doing what's not working. We want to make sure that it's consistent with national and evidence-based standards. We want to make sure that services are provided in the most cost-effective, least restrictive environment that is consistent with good clinical standards of care. We want to make sure that services are provided for the convenience, not provided solely for the convenience of the member, the member's family, the custodian, or the provider. That never happens. We want to make sure that services are not experimental, investigational, or unproven, or solely for cosmetic purposes. We want to make sure that services are furnished under the supervision of practitioners licensed under state law, that it's sufficient in amount, duration, and scope to reasonably achieve their purpose, and it's related to the diagnosis. We want medical treatment. We want treatment to be provided in accordance with person-centered planning, so that you are taking into consideration the wants and needs of the consumer as opposed to what's convenient for practice. We want it to conform to any advanced directives, medical directives that the consumer may have, and to be culturally competent. And finally, we want to be able to prevent the need for involuntary treatment or institutionalization. I'm sorry, a little Elliot coming out. So, meaning that we want to keep people as much as possible in the community. And so to do that, that means that we want to make sure that we're connecting them to the best services. All right. So real briefly, I wanted to talk about our benefit plan. So as Sean and Christy talked about, a big part of what we do in utilization management is to manage our benefit plan. Our benefit plan consists of clinical coverage policies 8A through 8E. Now you'll find the clinical coverage policies on the North Carolina DMA webpage under clinical coverage policies. So for example, those of you who are providing 8A services, those are enhanced services. Things like intensive in-home, mobile crisis, PRTF is 8D something. So that would be examples of what is 8A. So you can go to the clinical coverage policy website and you can find out what those services are. The ASPM 1026 January 2003, those are services like supervised living. So those are services like family living, high, low, and moderate. Again, you can find all of this information at the DMA website, and we will make links so that you can get that information as well. We offer 2 alternative state service definitions. Community activity and employment transition are for those of you who are old school Kate. And then hospital discharge and transition service, or HDTS, and Monarch provides that services for us for consumers who are high risk, high need consumers who are exiting the state hospital. We will cover 3 B3 Medicaid waiver services to start. Respite for adults with developmental disabilities and children. Now, the thing about B3 B3 services, they are only available to Medicaid consumers. So that they're great services, but unless a person has Medicaid, they can't receive them. Peer support, and we also will be covering community guide under developmental disabilities. And then we are also responsible for the E&M codes and all of the physician service codes that consumer incurs if they are hospitalized. All right, so let's talk about our service levels real quickly. And we have 3 service levels. We have basic services, and giving you examples of those. So for instance, a basic service would be clinical evaluation, individual, family, and group therapy. Now, why they're basic, you don't have to submit a person-centered plan unless the consumer is in an enhanced service. So you can just go ahead and submit your STR like you've been doing now to get those services. Basic augmented services require an SAR or an STR or a TAR if you would like, and it may require other documentation that you keep in your record. So for instance, for psychological testing, the documentation that you would keep in your record would be the psychological evaluation, the written evaluation. Again, this will be posted on our website so that you will find our phone numbers and our email addresses.
That is our meeting for today. I think Damien had mentioned that the general membership meeting was going to meet directly after this, so wherever the general membership meeting is going to be. Room 203. Thank you for coming this morning.